بسم الله الرحمن الرحيم. احنا بس طبعا بداية سعيدة جدا ان انا اشارك في هذا المؤتمر الذي يعني على مدار سنوات دائما عملاقا، والجمعية يعني الرائدة. واحنا ده دايما السيشن اللي هي بعد البريك، ده عهد السيشن على بال ما يعاد استكمالها مرة تانية، لكن احنا بنحاول نحافظ على التايم سكيدول اوف ذا بروجرام. فهيكون لينا شرف النهارده. الجلسه دي جلسه مميزه لان هي على اللان كانسر والمانجمنت اوف ذا لان كانسر، وطبعا بيشرفني ان انا بيشاركني في يعني اداره هذه الجلسه الفاضله الدكتوره هالة عبد الحميد. وهنبدا باستاذ الفاضل الدكتور احمد يوسف، ويعني لايف لونج ريليشن كده مع الكرايوثيرابي، وهي is one of the masters of the cryotherapy، وهيكلمنا ان شاء الله عن الكرايوثيرابي for the benign tracheobronchial lesions. والجميل في الدكتور احمد ان هو الحقيقه real life experience، فان شاء الله نسمع محاضره مميزه. اتفضل يا احمد بيه.
بسم الله الرحمن الرحيم. اولا احب ان اشكر الاستاذ الدكتور طارق صفوت والاستاذ الدكتور اشرف حاتم واخي الحبيب الاستاذ الدكتور احمد الحلفاوي على الدعوه الكريمه، والتشير بيرسون اخواتي الاعزاء. ان شاء الله احنا كلنا كنا عارفين ان احنا بنتكلم على كرايوثيرابي في المالجنانت تيومرز. المحاضره النهارده ان شاء الله هتبقى على البيناين ليجنز. Patient with lung cancer develop obstructing symptoms due to obstruction of the airway اللي هي الديسنيا والكف والهيموبسيس and frequently die من البوست obstructive pneumonia. طيب الاوبستراكشن ده mainly بالمالجنسي وزيه برضو بالبيناين تيومرز اللي هي ممكن تكون تيومرز، ممكن تكون ستركتشر، ممكن تكون فورين بودي. طيب هل الكرايو بس هو اللي بيستخدم؟ لا، احنا عندنا ديفرنت تكنيكس زي الليزر ممكن نستخدمه في المالجنت وفي البيناين، ممكن الالكتروكوتري والارجون بلازما، ممكن الستنت والكرايو ثيرابي، ودي الاجهزه كلها. طيب الموداليتيز دي ممكن استخدم حاجه واحده او ممكن بيبقى ان كومباينيشن، يعني ممكن ابدا بليزر واكمل بكرايو، ممكن بارجون واكمل بليزر، او ستنت في الاول وبعد كده اعمل جنريشن تيشو الكرايو. فعشان كده ان الموداليتيز دي يا الون او ان كومباينيشن. لو هي مالجنانت ليجن بيبقى فور باليشن، فور بيناين ليجن بيبقى attempt to cure 100%. زي ما حضراتكم شايفين الكرايوثيرابي والسكيمو والبيوت بتاعتهم من التلج. كرايوثيرابي ده جاي من برانش اسمه كرايوبيولوجي. كرايوبيولوجي ده عباره عن حاجتين، اللي هو السيل بريزرفيشن اللي هو بنحفظ بيه البلاد برودكت وبنحفظ بيه الاورجان ترانسبلانتيشن، او ان انا اعمل بيه سيل ديستراكشن اللي هو الكرايوثيرابي. ممكن يكون جنرالايزد ان انا باخد مثلا زي ما حضراتكم شايفين كده الاثليتكس دلوقتي بيعملوا زي الساونا، دي برضو حاجه كولد كده بيقعد فيها زي ليكويد نيتروجين، ودي بتحسن الجنرال ويل بينج بتاع العيانين، لان لقوا بتوع الاسكيمو لو تفتكروا حضرتك ما بيحصلهمش هارت اتاك، ما بيحصلهمش كانسر، بيعيشوا مده طويله. فده اللي هو بنسميه هيدروثيرابي يعني جنرالايزد. لكن لو انا خدتها لوكالايز يعني في حته واحده يبقى دي بسميها الكرايوثيرابي. ودي طبعا من الانشنت ايجيبشن بتاعتنا هم، وفي البيبرز اللي موجوده ان احنا اوائل الناس اللي استخدمنا الكرايو في التريتمنت اوف انفلاميشن. طيب التكنيك بقى بتاع الكرايو هاو تو ورك، وازاي يعمل لي الايس بول اللي موجوده بحاجه اسمها جون تومسون افكت. اي وات ايفر الجهاز اللي انا هستخدمه ان هو لما بيبقى موجود اندر بريشر وبعد كده يحصل سادن ريليز للبريشر بيعمل لي على طول الايس بول موجوده هنا. اللي انا بستخدمه كجاز ده اسمه كرايوجين. ممكن يكون ليكويد نيتروجين وده بيعمل لي فريزنج عند ماينس 196، او ممكن استخدم كربون دايوكسيد عند ماينس 80، او نيترس اوكسيد عند ماينس 90، او الفريون او الارجون. يبقى ممكن الارجون استخدمه فور هيتنج كارجون بلازما كواجليشن، وممكن برضو الارجون استخدمه فور فريزنج. ودي البيولوجيكال افكت اوف فريزنج ان عند ماينس 2 لغايه ماينس 10 بتبقى حوالي 90% من السيلز بتبقى فايبل، عشان كده بيبقى فيها بريزرفيشن. علشان استخدم بقى الكرايو ديستراكشن على الاقل يبقى -40 ان انا اوصل لها عشان يحصل لي 90% ديس للسيلز. وده دياجرام بيوضح لي الانترا سيلر والاكسترا سيلر كريستاليزيشن والديستراكشن. الديستراكشن بتاع الكرايو او هاو تو ورك بثلاث ميكانيزم. الميكانيزم الاولانيه اللي هو البايوكيميكال افكت اللي هو بيحصل ديستراكشن نتيجه الانترا اند اكسترا سيلولار فورميشن اوف ايس. تاني حاجه بالفاسكولار افكت ان هو بيحصل انترا فاسكولار هيموستيزيس، فبيحصل افتر 2 to 3 days بيحصل اسكيميا في التيومر سواء كان بناين او مالجنا. وثالث حاجه اللي هو الاميونولوجيكال افكت، ده نتيجه ان النكروتيك سيل بتطلع اميونو ستيموليتور. طب دي عرفناها ازاي؟ ان ساعات لما نيجي نعمل كرايوثيرابي للورد في الجلديه مثلا في الرايت هاند، وفي واحده على الليفت هاند ما حصلهاش تاتش للكرايوثيرابي، ليتر اون بعد 10 ايام ممكن تلاقيها ديكريس في السايز. ساعات برضو في اللنج تيومر على الرايت سايد ومعاه سكندريز على الليفت سايد، لو احنا عملنا مانجمنت وكرايوثيرابي على الرايت سايد للبرايمري تيومر افتر 1 ويك اور 10 دايز بلاقي فيه ديكريز للاكسترا او كونترالاترال سايد اوف لنج سكندريز. عشان برضه استخدم الانترفنشنال برونكوسكوبي واهمها الكرايوثيرابي لازم يبقى عندي يا فليكسبل برونكوسكوبي وريجيد برونكوسكوبي، لان ده فيه ادفانتج وهنا فيه ادفانتج. فلما استخدم الفليكسبل والريجيد بيبقى فيه الماكسيمم ادفانتج للبروسيجر، لكن واحد لوحده هيبقى فيري ديفيكالت ان انا اعمل بيه حاجات كتير قوي. ساعات بنسمع على تيرمز كده في الكرايو، يعني ممكن حد يقول كرايوثيرابي، حد يقول فيه كرايو كاناليزيشن، كرايو بايوبسي سواء كانت برونكيال او ترانس برونكيال، كرايو ابليشن، كرايو سبراي. كل حاجه من دي مش بنفس الديفايس اللي احنا بنستخدمه اللي هو الاربي كرايو، اللي هو ده يمكن ده موجود في معظم السنترز اللي موجوده. ده اللي هو الديفايس بتاعنا، وده السي او 2، وده اللي هو الفليكسبل كرايو برو. ده انكلوز الفليكسبل كرايو برو، وده الريجيد كرايو برو. في برضه استخدامات للريجيد كرايو برو في حالات السنترال ايروي، في حالات الميجور مثلا ليفت مين او رايت مين. لكن الفليكسبل عاده بيبقى افكتيف في اللوبر او السيجمنتال ليجن. ده اللي هو الكرايو بايوبسي برونكيال، ان انا باخد جاست بايوبسي، او كرايو كاناليزيشن لو عندي مثلا تيومر او عندي بلاد كلوتس او مثلا فاتس او اي حاجه، ان انا بعمل تاتش بالكرايو برو وبعمل كده ريموفال، فده بيعمل لي ريكاناليزيشن للايروي. وهنا ساعات بيحصل اوفر جروث بجرانيشن تيشو في الستنت، وهوري لحضراتكم حاجات احنا عملناها يعني انا عاملها في الحالات عندنا يعني. طيب يبقى ده كده كرايو ثيرابي. في حاجات تانية في حاجة اسمها كرايو ابليشن. يعني ايه كرايو ابليشن؟ لو انا عندي بريفرال تيومر في البريفري، والبريفرال تيومر ده كانديديت فور سيرجري، لكن العيان مثلا عنده كونترا انديكيشن او العيان ريفيوز السيرجري، فبنستخدم الاندوكير او الكرايو ابليشن. ده بيبقى زي البيركيوتينيوس نيدلز، يبقى دي بتدخل من بره. فزي ما حضراتكم شايفين كده على حسب التيومر ان انا بستخدم 1 أو 2 أو 3 نيدل اهي، يبقى دي فروم اوتسايد من بره. عشان كده دي بتسميها كرايو ابليشن فور ابليشن اوف ذا تيومر. ادي دي كده من بره، وهنا بعد الكرايو برو بعد الايفالويشن بتاع التيومر اهي. هنا مثلا التيومر بيبقى السايز بتاعه كبير، فانا بستخدم 3 من الكرايو نيدلز. طيب ليتر اون بقى في ديفايس ثالث اللي احنا بنستخدمه للكرايو سبراي. يبقى احنا عندنا كرايو ثيرابي او كرايو بايوبسي، في تاني حاجه كرايو ابليشن، وفي ثالث حاجه الديفايس اللي هو الكرايو سبراي. طبعا الكرايو سبراي ده اكسبنسيف، فاحنا في جامعه اسكندريه حورناه زي ما حضراتكم شايفين كده. ده بيستخدم للجلديه، وعملنا فيه البروب، وجبنا ده التانك فور ليكويد نيتروجين، فده بيبقى عند -196. نفس الكلام، يبقى ده ديفايس تماما خالص اللي هو الكرايو سبراي، وده ادي الديفايس بتاع الاربي اللي هو الكرايو ثيرابي. يبقى ده مختلف عن ده. ده احنا حورنا برضو الفليكسبل عشان استخدمه ثرو الفليكسبل برونكوسكوب. الادفانتج اوف كرايو تشيب طبعا كلنا عارفين، ايزي تو بيرفورم، اي حد يعرف يعمل منظار ممكن يعمل كرايو ثيرابي. نو بوسيبيليتي اوف برونكيال بيرفوريشن لان هو بيبقى الكارتريج بتبقى ريزيستنت. والحاجه الجميله بتاعته ان البيوبسي فروم اكستراكتد تيومر كان بي بيرفورمد، يعني ممكن دكتور الهيستوباثولوجي يعمل لها اكزامينيشن. الحاجه الوحيده اللي هو ديس ادفانتج اللي هو له ديليد افكت، فبيبقى مور ذان 2 or 3 سيشن ريكوايرد. دي كانت حاجه احنا عرضناها في ال WCBIB في مارسيليا، كانت على اليوز اوف ليكويد نيتروجين اللي هو كرايو سبراي في التريتمنت اوف اندوبرونكيال مالجنسي. لكن احنا النهارده هنوري لحضراتكم ازاي في البناين تيومرز. ايه هما بقى البناين ليجن؟ ممكن استخدم الكرايو فور ثيرابيوتيك اوبشن، واهمهم في البناين تراكيو برونكيال تيومرز. تاني حاجه في الفورين بودي اسبريشن. تالت حاجه في البناين تراكيال اور برونكيال ستينوزس، في الميوكوزال ويب اند ادهيجنز. وساعات دي برضو مع البلاد كلوتس، يعني لما تلاقي مثلا عيان دخلت على هيموبسيس وكده ولقيت معاه بلاد كلوتس، عشان تشفطها بتلاقيها بلاد كلوتد فعلا كده، فدي تعتبر كانها زي الفورين بودي، فبنخش بالكرايو بروب ونعمل لها فريزنج وناخدها ونشيلها، بتبقى مارفلس ريسبونس. او ممكن استخدمها كدايجنوستيك في حالات الانترستيشال لانج ديزيز عن طريق ترانس برونكيال لانج كرايو بايوبسي. دي حالات اللي هي كانت لايبوما بيفور اند افتر كرايو، دي حالات مالتيبل بوليبوزيس بيفور اند افتر كرايو، ودي حالات اميلودوزيس بيفور اند افتر كرايو. دي كانت حاله كانت لايف، كانت فيها ماس في الرايت لور لوب ويز كومبليت اتلكسس، وطلعت فيها لايبوما اهي زي ما شوف حتى الدنسي بتاعتها، واتعمل لها 1 سيشن اوف كرايو. هو الفات ريزيستنت للكرايو، بس احنا ما عملناش ديستراكشن، احنا عملنا ايه؟ عملنا زي كرايو كاناليزيشن، عملنا فريزنج ومسكت فيها اللي هو اللايبوما وطلعنا بيها مره واحده. الكرايو اند فورين بودي زي ما حضراتكم شايفين كده، احنا كان زمان كان عندنا ديفرنت موداليتيز للفورسيبس، كل دول كنا ممكن بنستخدمهم، لكن طبعا دلوقتي اتحط في الجايد لاينز ان انا بستخدم الكرايو بروب. من الحاجات الجميله جدا حالات البيناتس الصغيره والحاجات دي كلها برضه بتفيدنا في الاكستراكشن اوف فورين بودي. دي حاله زي كده، دي 1 2 3 وطلعت بسهوله جدا في الكرايو بالكرايو بروب. برضه نفس الكلام فورين بودي اكستراكشن. باشا الكرايو والسبجلوتيك ستينوز ده برضو من الحاجات الجميله جدا نتيجه البرولونجد انتيوبيشن. فاحنا عملنا في اسكندريه شغل حلو جدا عليها، زي دي حالات دي لايف، ان دي ادي السبجلوتيك ستينوزس. كنا الاول بنعملها بالالكتروكوتري بس، فكان بيبقى في انكريز ريسك اوف ريكارنس، فبدانا نعمل حالات وستادي، والحمد لله كانت ولا حاله حصل لها ريكارنس، ان احنا بنشتغل بالالكتروكوتري في الاول ونكمل بعد كده بالكرايو سبراي. اهو شايفين حضرتك الكرايو سبراي. الميزه ده في الكرايو ان بيبدا يعمل لنا نورمال ري ابيثراليزيشن للاريا اللي حصل فيها ستينوزس، فبالتالي بيحصل بيبقى جينس الريكارنس بتاعتها. فدي في السبجلوتيك ستينوز. الجرايو جرانيشن تيشو دي برضو من الحاجات الكبيره، كان دكاتره الانف واذن بيركبوا الستنت وبالذات الميتاليك ستنت، فكان بيبقى في حاجات كتيره جدا بيحصل زي ما حضراتكم شايفين كده جنريشن تيشو حوالين الستنت. فدي برضو ممكن نستخدم الالكترو، بس احنا كنا بنستخدم الكرايو. ليه؟ لان الالكترو مع الميتاليك ستنت ممكن الدايثيرم ده يحرق الستنت وتتقطع مننا، فكنا بنستخدم الكرايو زي ما حضراتكم شايفين كده. ادي الستنت وادي هنا طلعت كويسه جدا، وشايفين ادي السي تي بيفور افتر سوري، وادي السي تي بيفور الكرايو. شايفين كانت مخنوقه وسترايدر اند سو. دي حاله تانية برضو شايفين حضراتكم الفرق، جرانيشن تيشو حوالين الميتاليك ستين بالكرايو. شايفين الستنت بقت جميله واتشالت وحلوه جدا، والعيان بقى بوست كرايو يعني الديثنيا بتاعتها راحت خالص. ممكن استخدم كرايو وتيبيكال كارسينويد، لان احنا عارفين الاتيبيكال المفروض سيرجري. التيبيكال لو العيان ريفيوز السيرجري اللي احنا ممكن نعمل الانترفنشنال، وعملنا برضو حالات كتيره جدا، يمكن اكتر من يمكن 20 حاله، والحمد لله الريكارنس كان يمكن 2 حاله بس من ال20. دي كان حاله يمكن اخر حاجه عملناها من 3 شهور، كان بنت 22 سنه. شايفين حضرتك ادي كان في لوس اوف فوليوم على الرايت سايد، وادي التيومر. فكان حد من الزملاء عملها لها بس حصل هوربل بليدنج، فقلنا ناخد كرايو بايوبسي، فدخلنا بالفليكسبل وبعد كده بالريجيد كرايو. دي كانت ادي الماس وطلعت تيبيكال كارسينويد، واستخدمنا الريجيد كرايو بروب، وادي السي تي بعديها حتى كاتب توتال ريزوليوشن اوف ذا ماس. الكرايو ترانس برونكيال دي برضه الايرا الجميله في حالات اللي انا اشخص بيها حاجات زي كده بايلاترال انترستيشن، فبعمل ترانس برونكيال واخد البيوبسي زي كده بالسي ارم عشان البليدنج. زي ما حضراتكم شايفين بقى ترانس برونكيال بيبقى البيوبسي حلوه جدا مقارنه بالفورسبس. يعني انا ممكن اخد 6 و7 ترانس برونكيال فورسبس تطلع حاجه صغيره، ممكن اخد وانس او توايس ماكسيمم من الترانس برونكيال بيوبسي وبتبقى فيري illustrative. الكرايو والالترا ساوند دلوقتي بيستخدموه ان انا بدخل بالبرونكوسكوب وبدخل بالكرايو بروب. شايفين حضراتكم من هنا ادي الكرايو بروب، اطمن ان هو جوه تيومر، والالترا ساوند من بره واخد البيوبسي معانا. غير الايبوس اهي، الايبوس زي ما حضراتكم شايفين كده ادي الماس اللي موجوده هنا، ادي البرونكوسكوب ودي النيدل بالكرايو. فلما بدخل انا بالنيدل بخرم الليمف نود، وبعد كده بدخل البروب بتاع الكرايو بعمل فريزنج وبشد، بتطلع لي حته كبيره جدا. اهي نفس الكلام وهنا نفس الكلام. في البلورا طبعا من الحاجات الكويسه جدا نفس اللي في اللنج، ممكن عن طريق السوراكوسكوب ان انا باخد البيوبسيز واشخصها بدل ما استخدم الفور سيبس. وثانك يو فيري ماتش.
Thank you, Professor Ahmed Yusuf, for the usual elegant presentations and elegant intervention. We are asking, thank you so much, Dr. Ahmed. هنبدأ التوك الثانية مع Professor Grigoris Stratakos. He is an associate professor of respiratory medicine, University of Athens, and the head of interventional pulmonary unit, First Respiratory Medicine Department in NK University of Athens. And he's gonna talk with us about the stenting in airways in current status and future evaluation of airway stenting. Please, Dr. Grigoris. So we cannot hear you. I think maybe you're muting the voice. Still, we cannot hear you. We can see that you're talking, your lips are moving, but we cannot hear you. Maybe you should check the mute button or something. No, مش muted. في تكنيشن دعم عندنا هنا يقول لنا ايه الوضع؟ ممكن يتكلم من غير سماعه، ممكن يكون هي دي مش هسمع له صوت خالص.
Excuse me for that.
Yes, we can hear right now.
All right.
Okay.
All right. Maybe you can hear me now?
Yes.
Yes, we can hear you. Yeah. Yeah, please.
All right. Perfect. I'll try to share again. All right. And start with this. All right. Now, I guess you can also see my presentation.
Yeah.
All right.
Yes, we can see it.
Okay. So, good evening to everyone. Thank you very much for the invitation. And I'm really sorry not to be able to be there physically as it was scheduled. But I will try to still deliver my presentation on the stent current status and evolution. The indication for stent placement, of course, is regaining and securing patency of stenotic airways after having achieved patency. That can be due either to an luminal mass, which has priorly been removed, or due to extrinsic compression. It's very important to know that we cannot put a stent on an obstructed airway. A lot of colleagues often bring us patients or refer us patients for stent placement in whom the airway is completely obstructed. And they have to know that we have first to open up the airway to regain patency of the airway, and then put a stent if needed. So that can be due to malignant disease obstructing the airway, or iatrogenic complex post-intubation tracheal stenosis, or even extrinsic compression, either from malignant disease or benign disease. And of course, sometimes we use stents for sealing fistulas of the airway with the esophagus or the pleura. It is very important to agree and get informed that stent placement is not only palliative therapy, but also can improve survival. It improves functional capacity, improves quality of life, and improves survival of patients with lung cancer. And this has been shown now in many studies, and it is really unethical and unfair to deprive lung cancer patients from the possibility of regaining patency of the airways. This is a study we did some years ago where we found that the group of patients with lung cancer in whom we intervened had almost double survival than the control group who denied intervention for several reasons. And not only survival is important, but also quality of life. And you can see in this chart here, this is the active group in which we intervened, and this is the control group. You can see that the quality of life was increased right after the operation, which is reopening of the airways and stent placement where it was needed. And then when at 9 months we had relapse of the disease, we had again decreasing of the quality of life, which was regained after re-intervention. We can re-intervene to these patients as many times as needed in order to keep them alive and with good quality of life. The opposite happened in the other group. Of course, regarding the stents, which are put there to retain the patency, it's another thing to gain the patency, it's another thing to retain the patency, to keep the patency there for many months. And of course, for that reason, we need a stent which would be easy to place and remove, should be large enough to maintain its position, but not too large, and as concrete as possible to avoid granulation tissue formation. This stent should be flexible enough to mimic the airway physiology, coughing, speaking, but not too flexible, because it should have sufficient radial force to resist the airway compression. So it should be stiff enough. And this is contradicting. And of course, it should not impair mucociliary clearance. And to add to these new requirements of our last decade, we should add that this stent should be customizable in accordance to patients' needs, should be therapeutically active, maybe drug-eluting, and when healing process is complete, should be biodegradable. So this kind of stent does not exist yet, but we still dream and we still work on building this kind of stents. And of course, there has been a lot of progress since Charles Stent, who was a dentist in the 19th century UK, first implanted endoprosthesis in the denture to keep the denture correct after removal of teeth. And after him, all the prostheses in the human body have taken his family name as a noun, and we call them stents. So during the last 30, 40 years, there has been a lot of progress from the first and second generation of tracheobronchial stents. The first generation was this fixed diameter silicone stents, who was produced by Jean-François Dumont back in the 80s. And then it was followed by these metal stents, in the beginnings semi-covered and then fully covered. We call them hybrid stents. These are the first and the second generation of the airway stents. And of course, there is a big difference between them because these have stable fixed diameter. These are auto-expandable, self-expandable, and the wall-to-lumen ratio is better for the metal because they're much, much thinner, as you can see. and they are more applicable to irregular airways and to airways that do not have a regular geometry, while the silicone stents are very nicely accepted by the human mucosa, but they do not always adapt to regular airways. And of course, stents are complicating, and there are a number of complications which have been reported. Most recently, we have the incidence, which has been calculated to something like 1/3 of the cases, and most of the complications are retain secretion. We see that very often. Granuloma formation in both ends, migration. This is not so common, but it also happens. Pseudomembranes, which is especially in the beginning, the first months, it's a major problem. Fracture of the stent, especially the metal stents, tend to break, like you see here, and also endoluminal tumor growth. And this is one of the reasons why we keep putting less and less stents every year. This is from a talk of Hervé Dutot from the service of Jean-François Dumont in Marseille, where they calculated the use of stents in the last 30 years. And of course, they were the pioneers, they were those who invented stents. And you can see here in the first decade, they used 600 stents, all of them silicone, of course. And then the next decade, they used half of them, only 300. And then the third decade, they used half of them. So there is a reduction by 50% every decade. And of course, the last decade, they used some metal stents as well. And the reasons for that is that complications became much more apparent and indications became much more refined. In malignant cases, stents are required only when oncological treatment proves insufficient. We do not put stents if we do not know what will be the result of the oncological treatment. So we reopen the airway, and if the airway is stable, we do not put a stent. Only if the airway is unstable and the patient cannot breathe, we may think of putting a stent. In the past, we were putting stents much more easier. Also, fistulas can be treated only with esophageal stenting, and self-expanding metal stents also have some advantages. So they can also use in irregular airways. So what is the third generation? The third generation of tracheobronchial stent, which is underway, and they are already here, is airways patient and disease specific. And we could compare that, saying that it would go from the fixed pre-defined, pre-manufactured stents of fixed diameter to some specific stents, like going from pret-a-porter to haute couture. And of course, the first novelty is that we print out 3D print stents on the anatomy of the specific patient, of the specific airway. And so we can design the stent which is really individual for this patient, and also might be biodegradable when the time comes that this stent should be removed. So instead of removing stent, the stent may disappear. And also this stent could be used to deliver drugs and treatment. The basic procedure to build these stents starts from a good high-resolution CT with very thin slices. And this then is fed to a CAD, to computer-aided diagnosis platform, which isolates the airways and produces a 3D print model of the airways, together with a 3D print model of the lesion, of the stenotic lesion of the airways, which is then magnified. It's treated virtually, so we can create a model of the treated airway virtually before the operation arrives. And so we can prescribe literally a 3D print stent, which is anatomically and morphologically identical for this airway and this patient. And now that we have the form and the size of the stent, we can choose of what material we want to make it out. We can use medical silicone, or we can use a combination of polymers which are biodegradable. The most commonly used polymers are polylactic acid or polylactic glycolic acid and polycaprolactone, which are polymers with different characteristics, chemical characteristics, and different durability in time. So the mixture of these polymers can give us the final material out of which the stent will be made in the 3D printer. And so we decide first where to put the stent, what kind of stent we will put, and for how long we need it. Then, after we decide the material of which we want to make the stent, we put the 3D print stent on a stereolithographer, or we do selective laser sintering to cure the stent, to solidify the stent and give it the final physical properties. And then, of course, we have the final product, which goes to the hospital, and the interventional pulmonologist can deploy either a silicone stent of very specific characteristics, anatomical and physical, and of course some biodegradable polymer stents. Lutz Freitag was one of the first researchers who studied these 3D print materials and did the first 3D print stents, which are individualized, and they have also tapering of the thickness of the wall down to the length of the airway to adapt to specific resistances. And the last 5-6 years, there have been several publications. One of the first patients who was treated with this type of stents was in Toulouse, in France, by Nicolas Guibert, who printed out this stent for this transplant patient who had this dehiscence here in the transplantation suturing, and he covered it with this stent, which was produced the way I explained you. And of course, in the same year, we had this publication from the USA, from the group of Thomas Gildea, who studied long-term follow-up to patients with Wegener disease who also received silicone stents 3D printed. Nowadays, I can tell you that Novatec from France has taken the CE mark for printing out these kind of stents. Very recently, we had a patient for whom we ordered a silicone stent. It was very bizarre, very irregular airway. So we ordered a silicone stent to Novatec in France, and it came out after a few weeks. So you need some weeks from the order to the delivery of the stent. And of course, talking about biodegradable stents, we can use all this kind of polymers I told you earlier. And every polymer has its own duration and its own time for degradation. So we can mix this kind of polymers to achieve the proper time of degradation. And of course, there are studies ongoing. This is a very recent study with the mechanical properties of different polymer mixtures. So not only we know the time of degradation, but also the strength that we're waiting from this stent, and that goes down to the length of the stent, so we can have different duration and different strength to different parts of the prosthesis. And you can see here the studies. So we are going to make a very detailed biodegradable stent. And for the children, for the pediatric population, polydioxanone is the mixture, is the polymer that is used. There's several cases that the pediatricians have gone far with biodegradable stents. So there are several studies, many years now, with polydioxanone, and we see that most of them are treating bronchomalacia, fewer tracheal stenosis, and we know that polydioxanone is better for tracheobronchomalacia. So not only airway and patient-specific, but also disease-specific. If you have a child with tracheobronchomalacia, polydioxanone is the polymer that you need, and this can be biodegraded after a few months. And you can see here that the short-term improvement is very, very nice. Of course, there are some complications which reduce the long-term improvement, and the complications are mostly stent fragments. So some pieces of the stent are dropped in the airways and act like foreign bodies, or some granulation, or stent migration, or stenosis. Another very clever idea that is going out now in the literature, this is a publication from last year, is in situ in vivo modeling of the airway stent. So we put a stent, a soft polymer stent, over a balloon which is transparent to UV light. So we insert the stent here in the tracheal stricture. We inflate the balloon after having cleared the airway, after having removed the tumor, after having dilated the airway. We insert the stent. We inflate the balloon so the stent takes the form of the final airway. And once the balloon has dilated the stent to its maximum, then we insert a UV light and photopolymerize the stent. So cure the stent in vivo, in situ, and have the final product in the airway. And then, of course, this can be removed easily. It's like the dentists who stabilize the stuffing of the teeth in situ after they have finished their job. I think this is a very nice idea. Of course, we had to solve several problems like the possible complications of UV light in the airways, but I think that the research goes that direction. And of course, when we're talking for polymer and biodegradable stents, we should not forget that this can be done also by metal alloys, not only from polymers. So this is a study also 2 years ago for comparing magnesium lithium zinc alloy with other type of metal alloys, which are also biodegradable. And you can see here that this zinc, lithium, and magnesium alloy has a better physical activity and better physical performance, but also better biodegradation. And you can see that at 12 weeks, there is nothing left from the airway here, while in this alloy, there are a lot of necrosis and complications. So research is going there. I would like to show you where the things are going in the future. And of course, don't forget that we can also 3D print biological stuff using as an ink, not only polymers, not only metals, but also biological culture of cells. So chondrocytes, epithelial cells, and mesenchymal cells can be cultured, and then we create some artificial little spheres which go in the 3D print, and they print a cylinder here of this material, which is cured in the bioreactor, and then this is transplanted in the trachea of the animal in that case, but on the patient maybe tomorrow. So we can have an endogenous bio 3D print stent. I'm finishing with the drug eluting. Drug eluting is a technology that has been checked in the cardiology field. We can also introduce rapamycin and other immunosuppressive agents to avoid granulation tissue formation and other complications. We can insert them in the mesh or in the polymer mixture, and then we can implant the stent. And you can see here in that experiment that all the acute inflammatory markers as well as the fibrosis markers were reduced while the stent was embedded with rapamycin. So this is one of the ways we can avoid granulation tissue formation in stent placement. And this is, I think, my last slide, which is another idea, which is another study last year, covering of a standard stent. So we make a standard stent and we have them in our wardrobe, and then we have these coverings of the stent, which can be easily applied on the stent, and we have these drug-eluting polymer microchamber areas, and these microchambers can be filled with whatever drug you want. So we have a selection of pharmaceutical agents which can be inserted in these little spheres here, in these little microchambers, and then the stent becomes a drug-eluting stent with whatever pharmaceutical agent we choose. And you can see here that this is without the stent, this is the uncoated stent, and the coated stent with some antifibrotic agent has a better result. This is a new technology which is ongoing. So we will be very close to the engineers, to the biologists and pharmaceutical companies to create new active stents. And of course, stents can also be radioactive. This is a stent with iodium 125 seeds, which acts like a brachytherapy in the trachea. And you can see here that this kind of stent produces a better result in re-stenosis of the airway. So, to conclude, the brave new airway stent of the next decade will be customized in terms of form, size, and polymer substance, and will be patient, airway, and disease specific. There might be some progress in vivo molding and curing of the stents with predictable tensile forces, and these stents will try to make them more removable or bioabsorbable and degradable in a very standardized fashion. And of course, we have to predict time of and radial force curve of these stents. To prevent granulation and tissue formation and tumor growth, we can make them active with drug-containing and drug-eluting properties or radiation emission. thank you. I think this is a new world that comes up, and we'll have many more to see in the next years. Thank you very much for your attention.
Many thanks, Professor Gregoris, for your interesting talk about airway stenting. Next speaker, Professor Azza Nasr, Oncology Institute, will talk us about cyberknife in primary and secondary lung cancer.
السلام عليكم. أنا دكتورة عزة نصر بروفيسور في National Cancer Institute Cairo University. Okay. Consultant radiation oncology of Children Cancer Hospital 357. My talk today will be about the use of SBRT in lung cancer, in early stages lung cancer, and in lung metastasis, both. We know that lung mets is the most frequent malignant tumor, and it is the most leading cause of cancer-related death. And despite of the advances recent in diagnostic procedure, only 20% of non-small cell lung cancer can be diagnosed in an early stage. And we know that the recommended treatment for those patients with stage 1 and 2 non-small cell is the curative surgical resection. But in practical life, we can find that only 1/3 of patients that we can do surgery in them for multiple reasons, maybe age, operability risk, and these things. And historically, what's the substitute of surgery in these patients was the conventional radiation. But nowadays, those high operative risk patients, we are using SBRT. So which is usually now in the NCCN guidelines, which is our one of the most guidelines we are using. The oncology is the NCCN. It is used. SBRT now is used or written in the guidelines. What's the difference between the SBRT, or what's the SBRT and the conventional? Conventional radiation, that means we are giving a small dose per fraction daily on a long period of time, which is maybe in lung, we can use 5 or 6 weeks daily fractionation. But SBRT, or we are using a very high dose per fraction, is called stereotactic body radiation, which is using a very high dose per fraction in a very short overall treatment time, in about 1 to 5 fractions, and that's it. The whole treatment will finish in 5 fractions. This can be used both in lung mets and in radical in early stages non-small cell lung cancer. We are using high dose because it should be in this condition. In high dose per fraction, we can reach a very high radiobiologically effective dose, more than 100 gray. The gray is our unit in radiation oncology. So what is the advantages of SBRT over the conventional radiation? It's, of course, outpatient procedure as any radiotherapy treatment, but the overall treatment time is very short. The treatment finishes in a couple of minutes, and the patient can do his daily activity while receiving his treatment after finishing the session. No sedation, no anesthesia are used. So how can we use the SBRT? First of all, we use it in small tumor volumes. Second, we give a high dose per fraction in a short treatment duration, as we said, from 1 to 5 fractions. And in this condition, we give many beam direction, even in CyberKnife, which is the machine we recently introduced in our hospital, Children Cancer Hospital. We can give, the robot can move from all directions, and this gives us the probability of doing a very steep dose gradient. What's the importance of the steep dose gradient? That the high dose of radiation will go directly to the tumor, and we can be able to save the normal tissues around the tumor, and this will be reflected in lesser side effects of radiation. All this procedure should be very accurate in both delivering the radiation and monitoring the patient during receiving his treatment. The most important or the major challenge when are giving radiotherapy to the lung, either primary or metastasis, is dealing with the tumor movement during respiration, the tumor and the normal tissue, dealing with the managing respiratory motion of both the tumor and the normal tissue. In our radiotherapy field, we have so many techniques to overcome this problem. But most of these techniques should have the cooperation of the patient. But the most important or the most recent one, which in the CyberKnife, is the tumor tracking and motion management technique. This is usually done. This is the CyberKnife, the machine. It is a linear accelerator or a radiotherapy machine having many cameras. Here there is 2, and there is one for the movement of the respiration. And here's the patient lying very comfortable, breathing freely. In our field, we know what's the importance of that. As I said, all the other techniques needs a very good cooperation from the patient. But here we don't ask him for anything. He lies comfortable in bed, breathing normally, and the machine is doing the whole work. Getting his normal moving respiratory rhythm and moving with the tumor while the patient is breathing. This can give us the opportunity of what? If this red is the tumor, so I can, in order to, usually we take a safety margin around the tumor of the normal tissue to be sure that the tumor always during radiation is inside the radiotherapy field. In real-time tumor tracking, which is in the CyberKnife, I can take only a small amount of normal tissue around. In the other techniques that overcome the motion during respiration, we can take a larger amount of normal tissue around in order to be sure that the tumor always inside the treatment radiation field, whatever the movement is. This is reflected also on the side effects of radiation on the normal tissue. That's how come it is markedly reduced with the CyberKnife. How to choose the patient for treatment with SBRT? There are so many guidelines. One of them is ESSB and others. They are usually we choose the medically inoperable patients or patients who refuse surgical resection. There is no absolute contraindication for lung SBRT. A minimum performance status of 3 and a minimum life expectancy of 1 year. And the upper limit of tumor diameter should be mean 5 centimeters. As we said, it is delivered in 5 fractions, but sometimes outside United States, we can use it they are used from 6 to 10 fractions. But in all conditions, the dose should be high. Why we replace the conventional radiation, the radiation given over 5 or 6 weeks, with the SBRT that it is given over 5 weeks only? We have so many studies, but there are 2 major studies done. These studies changes our treatment guidelines. One of them is the SPACE trial, and the other, I don't want you to go in details, and the other is Chisel trial. Both of them were multicentric phase 3 trial, randomized trial, and having a large number of patients, more than 100, and all the patients were T1 and 2, N0, inoperable, or refusing surgery. And one of these studies proved on both aspects, the effectiveness and the toxicity. The effectiveness was very higher than the conventional for the SBRT, and the toxicity profile favored SBRT. We cannot judge only the effectiveness, we are so concerned also about the side effects. The side effects or the toxicity and the effectiveness of SBRT was higher than the conventional radiation. In conclusion, for all the studies in this issue, that patients with inoperable peripherally located stage 1 non-small cell lung cancer compared with the standard radiation, SBRT resulted in superior local control of the primary disease without an increase in the major toxicity. And these findings of this trial suggest that should be the treatment of choice in this group of patients. And of course, very important is to know how to deal with the motion challenge of the tumor and the surrounding structure. All these studies were on the peripherally located tumor. What about the centrally located lesions? Centrally located lesions mean that within the 2 centimeter from the central structure, like the central airway, the brachial plexus, the esophagus, the major vessels, the heart, and the diaphragm. We have an RTOG trial that also proved that it is very effective with loss toxic in the centrally located patient lesions, the one I said before. And the importance of this RTOG is that those patients, this is an important achievement, that before that they were not treated at all. They are inoperable or refusing surgery, and the radiotherapy was very high side effects. But with SBRT, this study provides data about the safety and efficacy of 5-fraction SBRT schedule that is well tolerated and associated with relatively low rates of serious treatment-related toxicity. Another step forward about dealing with the ultracentral tumor. Ultracentral tumor, they are less than 2 centimeter or adjacent to the important central structure that we mentioned before. And there was a study published about a retrospective review of all the patients which are centrally and ultracentrally, proved also the effectiveness of SBRT, but further larger series will be required to fully establish the safety profile of SBRT for ultracentral tumors. A further step forward was comparison, a single-arm prospective trial done at the University of Texas, comparing those who are operable, not inoperable patients, and they are comparing those who received SBRT with those who did surgery, radical surgery. And these results show that SBRT is not inferior to the surgery in this group of early stage patients, although larger studies are needed. And this was published in Lancet Oncology. Lancet Oncology is one of our major journals in the oncology field. And there are so many now studies about comparing SBRT versus surgery. So in summary, a patient with a standard operative risk should go for surgery. Those who high operative risk should go for SBRT, and dealing with the tumor motion is mandatory for implementation of SBRT. And this is for all peripheral and central lesions. What about lung mets? Of course, lung mets develop in 20 to 54% of cancer patients at some point of their disease. Historically, of course, the treatment is systemic treatment. However, many recent evidences come from retrospective and prospective series indicating improved long-term results when local treatment is added to the systemic treatment, local either radiation or surgery for these metastatic sites. And one of these large retrospective studies was done in German working group, stereotactic radiotherapy, containing 700 patients treated with SBRT from all or many German radiotherapy departments. And lung mets were treated with a median dose of 12 in 3 fractions. And the results was very encouraging. The 2 years local control and overall survival were 81% and 54% respectively. And in multivariate analysis, the overall survival was most significantly influenced by the pretreatment performance status, the maximum metastatic size, the diameter, the primary tumor histology, the interval between primary tumor diagnosis and SBRT treatment, and the number of mets. So another study done using CyberKnife, like our machine, and it shows patient with oligomets were treated with CyberKnife, and the dose was 60 gray and 3 fractions. And the 1 and 2 and 3 years local control rate was 89, 80, and 77% respectively, and the overall overall survival was 92, 80, and 72%. And the vast majority of patients developed no toxicity at all. So we can conclude that SBRT is a highly effective local therapy for oligo-lung metastasis and could achieve long-term survival in patients with favorable prognostic features. The last slides or last thing was an abstract published in September 2022 in the Journal of Thoracic Oncology dealing with the stereotactic body radiation for primary and metastatic lung cancer using CyberKnife M6, which is the one we have in Children's Cancer Hospital. And it's giving the same conclusion. They studied many patients, giving the same conclusion that CyberKnife M6 lung tracking system, it allows for the application of free motion management strategy. And in this study, excellent local control with a median survival of 23 months was achieved for primary and metastatic lung cancer, with a median treatment time 26 minutes, and it is non-invasive. It was efficient, safe, and comfortable treatment for lung cancer, primary and metastatic. Thank you so much.
Thank you so much, Professor Azza Nasr, for this illustrative and elegant presentation. And now we go to Dr. Peter Harper. He is a leading consultant of St. Guy's Hospital and St. Thomas Hospital for over 25 years. One of the 4 founder partners of London Oncology Clinic, and he will present to us what to do for harm reduction, how to reduce the harm.
Thank
Please.
you. I'm standing between you and lung transplantation rather than your lunch, so I'll go quickly.
Would you please put the mic up?
Can you hear?
Yeah.
Yeah. So the management of lung cancer, but what I want to do is speak about how you shouldn't have lung cancer. So I've spent my lifetime treating lung cancer, hundreds of papers, hundreds of phase 1, 2, and 3 trials. But I think that unless you take some action and change, you're going to need many thousands more. So I'm an oncologist. I fought very rigorously about stopping smoking all my life with quit clinics, many multi-center lung cancer trials, and a board member of ISLAC, and indeed on the board of ASCO. So been a consultant to several pharma companies, and I'm now a consultant to Philip Morris, but exclusively on reduced risk products, because I think if you don't adopt them, you are going to sail into oblivion. So risk factors and smoking is a pretty small list. It's smoking. It is smoking. It is smoking. You've got to stop combustible cigarettes. The rest of the risk factors are tiny. So unless you address the big ones, you're in trouble. How successful have we been at reducing the actual numbers of people who smoke, of the population? So if you look over this period from 2000 to 2025, and if we look at the in the year 2000, the total was 1.12 billion smokers. If you look at the WHO prediction, that is going to be just under 1 billion in 2025. This is an awful lot of smokers. Quitting is best. Quitting is difficult. If you have developed lung cancer, a study showed that 64% of those patients were unable to stop smoking, despite good evidence that if you stop smoking, you do better. You can't stop. As an oncologist and as a doctor, you will know if you don't change the number of smokers, you will not change the number of lung cancers and other smoke-related disease. 1 billion smokers, 8% will develop lung cancer, 80 million lung cancers, 64 million lung cancer deaths. You've got a problem. So let's look at Egypt, and let's just look here at what we've got in terms of Egyptian smokers. Tobacco use in Egypt, prevalence 25%, but in males it's 49%. You're going to have no men left. You're going to be a nation of ladies. Looking at the numbers you've got now, it's irrelevant. You're looking here, your number of lung cancers, not very many. And that's because you haven't been heavy smokers for long enough. You are going to not be any better than any other nation. You are going to have a vast number. If you look at the ranking in 2019 compared to 1990, smoking remains your major issue in terms of cancers. And if you look at all this list, all of these, other than particulate matter pollution, are your choices. Low physical activity, obesity, high plasma glucose, unsafe sex. They're all personal choices. So the concept of harm reduction is here, and you need to look at the data. All I'm asking you as doctors, physicians, is look at the data. Do something to try and stop what's going to happen. Harm reduction's been around a long time. You have fast cars, government makes you put in seatbelts, airbags, disc brakes. You have an unhealthy diet, we give you statins, stents, we've just been talking about, anti-aggregates. We teach the blondes not to go out in the midday sun, but if they do, for God's sake, wear a sunscreen. We try and look at sugar replacements, we give you condoms, and we say don't have HPV. So we do lots, but we need to do more. And for many years, we've mistakenly looked at nicotine as the culprit. Nicotine is a culprit, but it's the culprit of addiction. It's not causing the cancer. So I have become converted to looking not at eliminating tobacco, which I don't think I can, but to eliminating combustion. How does cigarette smoke cause cancer? And what you know is if you burn the plant, you release the tobacco-specific nitrosamines, and they are vicious and they will give you problems. If you heat and don't burn, keep the temperature below 350, the release of those specific nitrosamines is very low. Can you do it? Has it been done? We're going to talk about 3 innovations. We're going to talk about snus, e-cigarettes, and heated tobacco products. And I don't personally mind which you use, but stop combusting. So snus has been around over 50 years. It's a little tea bag you put under your top lip. It's very specific tobacco. It's a pasteurized tobacco, and it has a very low heavy metals. It's been proven to give in Sweden the lowest rate of tobacco-related cancers and tobacco-related disease in Europe. Here you can see a rate of 152 per 100,000 attributable deaths. Here you can see the EU mean of 373, and here you can see Hungary at 699. So that is 400% higher than Sweden. So what else can you do? You can innovate, you can vape, you can take the nicotine if you've got to have it, or you can have a bit more paraphernalia and you can actually have tobacco, but heat it, don't burn it. UK has adopted this and it's made a very substantial difference. And what you can see is the UK 2012 to 2017 you began to introduce a bit of e-cigarette use, vaping. In 2014, we announced that it was substantially safer, if I can use that, less harmful than smoking, and the rate of smoking combustible cigarettes came down. We're now at 14.2%, and we still have around 5% of vapors. So this is the view of Public Health England. Harm reduction is saving lives. Is it ethical to ignore this? Every minute someone is admitted to hospital from smoking, 79,000 deaths a year in England, so that's excluding Scotland, which is a separate health authority. Our new review reinforces the finding that vaping is a fraction of the risk of smoking, at least 95% less harmful. Reducing the prevalence of smoking by 1 percentage point each year for 10 years would prevent 69,000 deaths, which are young, 35 to 74 years. It would be tragic if thousands of smokers who could quit with the help of an e-cigarette are being put off due to false fears. So what about heated tobacco products? If you use a smoking machine and puff a cigarette, combusted through a filter paper, that's what you see. If you use a tobacco heated system aerosol, that's what you see, which is largely water and glycerol. And the FDA reviewed the evidence on heated tobacco and issued in 2020 a modified risk tobacco product license. The product they looked at was IQOS, no combustion, reduced levels of toxicants. It completely agreed with the evidence that was already there. They looked in the Southeast Tobacco Laboratory. Everything was reduced. IQOS has a lower toxic potential than cigarettes. We all agree risk reduction in cancer is not demonstrated, and it will not be demonstrated for 10, 15 or 20 years. But the evidence is that you have less carcinogens, 90 to 95% less, and that is likely to be reflected. So let's just look now at Japan. So Japan has adopted heat not burn. Cigarette sales have dropped precipitously by 4 billion sticks a year. The heated tobacco products have risen, but you're still well below the difference you've made in reducing cigarette sales. And very interestingly, you're now beginning to see COPD acute admissions have dropped, coincidentally with the rise in heated tobacco use, and the ischemic heart disease hospitalization, acute hospitalization rates have dropped. You're beginning to see what we expected to see. It is an association, it is not a proven relationship. Before smoke-free products could impact smoking prevalence, you had all your tobacco control mechanisms, and Australia was the poster boy or poster girl. 16% combustible cigarettes in Australia, 18% in the UK, 18% in New Zealand, I've rounded up and down, and 19% in Japan. With the coming of information on e-cigarettes from Public Health England, Australia doesn't allow them. It drops by about 1% a year, which is normal. The UK came down precipitously by 3%. New Zealand also came down by 1.6%. But nothing happened in Japan because they don't have e-cigarettes. When you had the heated tobacco products available nationally in Japan, you can see Australia still continues to come down by 1% a year, doesn't have any product. The UK has come down precipitously by now down to 14%. New Zealand has come down by 14%, a very enlightened attitude there. And Japan has come down to 13%. So what you can see is the introduction of products which we believe to be less harmful is making a substantial difference. So what about regulation? I believe you should regulate. I'm not looking for unregulated vaping or any other product. But quite interestingly, we've been watching the e-cigarette use in the UK amongst never smokers and youth. The proportion who never smoked, who use electronic cigarettes at least weekly, remains very low, 0.2%. Now everybody thinks it's 5% or 10% or 15%. It isn't. Kids are going to experiment, and if you look at cannabis use under 18 in the UK, you might well be shocked. So my conclusion is tobacco is the leading cause of lung cancer. Quitting is what you've got to do. Current strategies have failed. You've got 1 billion smokers remaining. Harm reduction may play a part, and I think you can see there is evidence. This is going to have to come from government. It's going to have to come from you, the doctors. It's going to have to come from respiratory doctors and cardiac doctors, as well as oncological doctors. And as I conclude, as a doctor, considering harm reduction for the patient, my individual obligation to the individual patient outweighs any other considerations. And that is why I'm speaking about these methods of reducing toxicity. Thank you.